Music. All right, it's showtime again. Welcome back. This is our second session that I am so excited about. We have our guest today, Dr. Lee Stromer. He's a very, very well-known, first of all, it's a very well-known name in the Dallas area. I met Dr. Stromer in 1989 when I was working for a laboratory in Louisville. Dr. Stromer was, when he walks into this lab, everybody is like, oh, Dr. Stromer is here. You know, so this gentleman is so knowledgeable. He wrote a book on
removable dentures,
Right, and everybody looks up to him and learns from him. So he's here with us today, and I am so glad to have him as our speaker. So hopefully you'll enjoy the next hour and a half. And I know you will. So I've seen his presentation before. It's great.
And we'll have questions at the end.
And then we'll have time for questions again. And he has some printed material. If you like to pick it up on the way out, please do so. He made the effort, to print it out for you. I have a small announcement from the hotel that in the hallways, since we are sharing the hotel with FEMA, to please put the masks on at all times in the hallways. In the rooms in here and the exhibit hall, they're fine with it, not having the masks on, but in the hallway area, the restaurant and all that, please let's respect their wish. So appreciate it, and please help me welcome Dr. Stromer. Thank you.
Thank you. Thank you. Can everybody hear? Is it fine? Good? Okay, thumbs up in the back. That's great. So I'm going to be talking today, clarifying the fundamentals of complete denture fabrication. So important to know and follow the fundamentals. There's so many things that are trying to make things quicker and faster, and dentures already are a big challenge. We're going to talk about that, and dentists say often they're so unpredictable, and we have to pay attention to these fundamentals. And we're going to be talking about edentulous restorations today. Not immediate dentures, but if somebody comes into the office with no teeth, how do you figure out where those teeth go? And I'm thrilled to be here with the Dental Laboratory Association. So, disclosure, I have no conflicts of interest that would affect the content of this course. I'm not being paid for this, and Ivoclar Vivadent invited me, but they're not paying me either, so I can say just what I want. Just a little bit about who's talking to you. Dr. Lee Stromer. I practiced in Dallas, Texas for many years. My first mentor when I came to Dallas said, "Go hear Dr. Pankey." Maybe some of you all know about Dr. Pankey, the Pankey Institute. And I went down and didn't know what he was talking about in reconstruction, and went back. And I started learning about equilibration and TMJ and reconstruction of teeth mostly, but I also started taking courses in dentures, and just like most dentists had, big challenges with my dentures. I started working on my mastership in the Academy of General Dentistry, and I took a course by Dr. Earl Pound, and good Lord, it was just like the light came on. It just, all of a sudden, I started seeing why I was having so many problems. So I started hanging out with Earl Pound. That was in the mid-'80s, and he would, when he'd give give a course, he'd let me come and help him teach the course. I wouldn't help him teach. I'd go get him a glass of water and sharpen his pencil, and he'd do demonstrations so I could watch that. And so I started copying his work and started having success with it. And I actually wrote a book on Earl Pound's work, and that's the book that I've written called Restoration of the Edentulous Mouth. And it's a more advanced work, but it goes into so many ways of making a real fine restoration for people. For about the last 10 years, I worked in East Texas in a large lab there, a large dental office there, and I was doing all of the removable work. So I got a system that I'll say where I was being successful with my dentures, and that's a lot what I'm going to be talking to you about today. And down at the bottom there, my passion is to help each one of you, help anybody be a better dentist. That's just where I am now, and so I'm thrilled that you're here for this program with me. So, treating the edentulous patient can be a very enjoyable and gratifying time for the dentist, for the dental team, including laboratory technicians and the patient. But I'm going to say the dentist and the team all need to focus on doing the steps we're going to go over this word, in an adequate way, in a way that's going to work. And by taking shortcuts and cutting things out is not the way to make fine restorations, and not the way to have predictability and a happy patient. So, dentures are such an important service also. I consider these people, they're like disabled people. A disability means it affects your way of life. And so, somebody that doesn't have any teeth, that they can't chew, they're have lower self-esteem, and so we can do so much for these people. And so dentures are a really cool thing that we can help people so much. And once you get the basics down and are helping people with nice dentures, another thing they're so cool, you can make very aesthetic dentures, and you can work with the gum level and contours and put beautiful teeth in. So many cool things we can do with dentures. And a point about the fundamentals, coaches are always saying, focus on the fundamentals. We've got to do the fundamentals. Vince Lombardi said, and the great football coach, excellence is achieved by mastery of the fundamentals. And I know that Michael Jordan would talk about the fundamentals. And so these are the greats. And so y'all are the greats. And so watch these fundamentals of dentures. And then so after the fundamentals are mastered, then I recommend that's time when you really start getting into maybe working more on aesthetics and the phonetics of your dentures, and staining the denture base, and putting implants to support dentures. But sometimes dentists are off doing, let's just say, staining denture bases and making a beautiful base for you. Well, if you're not making a good denture, you know what I'm saying. So first, master the fundamentals, and then number two there, many steps can be delegated to dental assistants and dental laboratory technicians. So, but everybody has to be on the same page of doing adequate work. So let's hit this word adequate, and actually I got it with this word and this concept. I was such a perfectionist, can drive you crazy. So somebody, a coach that I had, introduced me to this concept, and it worked so well for me. But what I want to stress is if we do something adequate, that means it'll work and it'll work well. So you'll hear me say that. It's not like, oh, this impression, yeah, we missed it didn't get back to the hamular notches, and we got some big bubbles, so, but it's adequate, let's just go on. Adequate means something will work well, and I hope that y'all will make adequate restorations and be part of a team doing that. So an adequate denture is a denture that has good aesthetics. It's not some, it'll get by, go ahead. No, we have good aesthetics. We've got good stability and retention. We have a vertical dimension that works for the patient, not too far open or too far closed. And we have good occlusal stability where all the teeth come together and all hit evenly in centric relation occlusion. Another term is excellence, and I look at that as a journey, and anybody can, right out of dental school, if you get on a journey of excellence, or tomorrow you can. And what that is just a journey in life or a journey in dentistry of striving to be better, be a continuous student, and apply these things to turn out a better product. And I'm just going to mention the word perfection. I taught at the dental school for a while, and some of those instructors, oh, you got to make this perfect, make a perfect crown. And well, perfection is something that can't be achieved. And a perfectionist is never satisfied. And so also, for myself, in just focusing on making this perfect, sometimes, well, hey, you can learn and try these things. No, I can't do that. I've got to get this perfect here first. And so perfectionism actually can crush enjoyment of life and growth. So let's have something adequate and keep learning and making our what we're doing for people better and better. Here comes a patient in, and they don't have any teeth, and so when they come into the dental office, I like to say you never know what you're getting into with an edentulous patient when you're going to fabricate an edentulous restoration. How much room do you have for vertical dimension? How's that tongue going to affect things? So there are just so many things that come into play. So you never know what you're getting into when you start. And I like this. I've looked at this picture a lot myself. But here we've got a skull with the teeth, and when teeth are removed, all that supporting bone is gone, and look at there on the right. And then so somebody comes into like that on the right, well, where in the hell did the teeth go? I'm trying to get the teeth back the way they were before they were restored. Well, you don't have any guidelines much over that way. The way that the bone resorbs after extraction of the teeth, it's not predictable, and you can't say, oh, everybody, you should do this or that. But isn't that something that there on the right that, and so here just shows, oh, sorry. There's see how far the teeth are on the upper, out in, out in front of the remaining bone. So you can't be saying, oh, I'm going to put the teeth over the ridge. Look how much bone is lost on that lower. All that bone is resorbed in the teeth. And so trying to figure out where, where the denture base is and where the teeth are is a real challenge. And here's a case, just a lower, to look at that ridge. No, I wish I could get this. The Retromolar Pads, well, one more time here. So can you see my little pointer right over there, the retromolar pads? So all that shows you about where the occlusal plane level is. All this bone has been resorbed, and we got a plan where the teeth go in, and denture base build up there. And a young dentist said to me recently, said, I just want to know where to put the front teeth, and well, we have guidelines that we have here on the left. Here is the incisive papilla, and an average is the anterior teeth are 9 millimeters, 8 to 10 millimeters anterior to the incisive papilla, but it's not always the same. So there's artwork that goes into this. It's not a quick put it in the computer and choop, they'll mill out a denture for you. Because look at everybody's not the average, and so maybe this lady here, her anterior teeth might be 9 millimeters anterior to the incisive papilla. But look at this one, the teeth are a little bit further, and this one they're even further forward. And so you can't just have it a certain way that for everybody. So that's why the wax try-in is so important, so you can manipulate things to get where you can make changes. And this is just to show again this is where the incisive papilla is. It's right behind the central incisors, so the teeth we're out in front of this, but how far out in front of it? We're usually 9 millimeters out. And so when the laboratory is making a wax rim, we'll see, we want to make the wax rim maybe wherever the dentist says, but 9 millimeters anterior to the incisive papilla. Then it's easier for the dentist, we'll be seeing this, to fine-tune the wax rim rather than a wax rim coming back that's not close to where the teeth will be going. So here's just a slide showing here on the right. This is where the tooth is. Of course, the cast was cut in half. But after that tooth is extracted, like if these teeth were all extracted, we are losing bone, like this bone. This is where the gum and bone is on the buccal of that root there on the right. And so when that tooth's taken out, it's resorbed, so all this bone is gone. And then so dentists are setting teeth over the ridge, and look at the difference. And so if we're setting teeth over the ridge, this is what we might be doing. This is Jim here, left and right, but these teeth for him, this is a motorcycle guy and beer drinker, bowler. I remember talking about that. But he just had a horrible looking denture, I think. You just look at him across the street and say, that guy's got a denture. But so if you follow some of the fundamentals, we can get a much nicer look for him. So this is putting teeth. The teeth are too short and they're too far back. So I'm going to introduce, and in the handout that you'll get, it has a lot of these products written down, like the Alma gauge and just different things, which I think are real important for you to have, for the dentist to have, because it's so important for the dentist and the laboratory to communicate. So the dentist says, this is what I want, and the laboratory say, well, I need this. And we just talked about the average distance from the center of the incisive papilla to the anterior surface of the central incisors, 8 to 10 millimeters. And if you have an Alma gauge, this little plunger comes right down into the incisive papilla, and this little these measurements show how far anterior the wax rim is to the incisive papilla. And so we can make it whatever the dentist wants, or if the dentist doesn't say, a good average would be 9 millimeters forward. And then the wax rim is going to be a lot closer to the where the teeth are going to go. And this just shows also that if the dentist here on the left, this is the old denture, let's say it's worn out and it has some problems, but if you really like the length of the teeth and how far forward they are, with this Alma gauge, you can, the dentist can give the laboratory measurements so that the wax rim comes back very close to the way the denture was. Or you can say, well, I want you to add 2 more millimeters of length, so if you knew what the length was, you can, so this gauge right here will let you know how the height of the teeth to the ridge, and if you wanted those teeth to be a little longer. So it's a great communication tool. I couldn't practice without it. As we're talking about the fundamentals, I think it's so important for the laboratory technician to know the dentist part, and the dentist as much as they can to know the laboratory part. And so we're going to be talking just about some of the fundamentals of the complete denture service for the examination appointment, some of the things that the dentist should be looking for, and if they're not looking for it, they're probably getting less predictability of their restorations. And then what are the fundamentals that we need in our final impressions? How do we determine and record vertical dimension of occlusion and centric relation? And the fundamentals of tooth position. So we're going to have if we have a nice maxillary aesthetic wax rim, we can communicate tooth position to the laboratory. And we're going to talk about the wax try-in. That's something that concerns me about the digital dentures is they just make a restoration, and it's harder to do the little nuances. So I'm saying know what the fundamentals are, and then there's so many different things that you can add to your service, like digital dentures, but at least you know what to expect from the digital denture service. Processing dentures, it's so important to have a system that controls the shrinkage of the acrylic resin and delivering dentures and laboratory communications. So let's talk now some about the first appointments, the examination appointment, and just a couple of the things that the dentist is doing at this time is evaluating the conditions and the health of the intraoral anatomy and the TMJs. So sometimes a patient comes in and their joints are not healthy, their mouth is not healthy, but the dentist says, we got to get those impressions. Get started, make financial arrangements, and take impressions. Well, if we're having problem with amount of saliva or TMJ dysfunction, and those things, that's where a lot of our unpredictability comes, because these things are right there to see, but the dentist will just kind of swish through it and get started. So if the laboratory knows this, and there's a team, the laboratory can help educate the dentist too. So, and in the consultation at this appointment, something so important is to listen to the patient. And so make sure your dentists are doing that, or if you're a dentist, listen to what is the patient expecting? They're expecting to be able to chew like they could. Yeah, these dentists are making all these terrible restorations for me. I want to chew like I could when I was a kid. Well, that's probably not somebody that is going to you're going to have a success with. So as we're looking at our cases, if somebody has a torus, or they sometimes have large toruses, say a buccal torus on the ridge, sometimes these are just cases that should be implant cases. And another thing, if they have a torus like this, just to mention something, that make sure that when you make your denture base, it's full thickness over this torus, because often a denture will rub on the torus grows, and if you start grinding out the inside, you penetrate through the denture base. So I think this is what I do is I'd say something like to the patient that I'd show them this bone growth and say that when the denture fits over that, it's going to take space in your mouth. So it's going to feel like your mouth is full, but that's the way it'll be. Just expect that with the final denture, because you've already got this taking space, and then you're going to have the thickness of the denture base over it. And I think you should have at least 3 millimeters of denture base thickness. Here somebody comes in, and this is that Jim that I showed you with the short teeth. So he came in, but many dentists will, a patient will come in like this, and they'll say, "Let's get started on your denture." But just to realize, so this is the same mouth on both sides. This is Jim later, but you take an impression of something like this, and you're making your denture to this. And then as things start to heal, because you might not have all the irritation to the denture, well, if he gets like this, well, this denture is not even going to fit. So you see, there's so many things that then the dentist might say to the laboratory, "Well, you messed up. You didn't process it right." So, but isn't that interesting? What a difference it is. But hopefully if a dentist sees something like this, he's going to say, "Hey, you need to have some tissue conditioner used to get your gums healthy, and then once they're healthy, then you can take your final impressions." So these are just some of the fundamentals. The fundamentals are work with somebody in a healthy condition. If they're having TMJ problems, I might mention too that you can make a denture to jaw joints that are unhealthy, and then if things change and the jaw joints settle back in, then the occlusion changes, and then I guess the dentist a lot of times wants to blame the lab. "You just didn't mount it right." So there's so many things that so the dentist, I recommend in my courses that the dentist is really checking the temporomandibular joints, like Pete Dawson talks about, to verify centric relations. So, but you need to be working with a healthy situation to have predictability and then turn out an adequate product. So let's mention a little bit about final impressions. It's so important that we get the appropriate anatomy in our impressions. I'll see when I go to the laboratories that sometimes the upper impression does not include the maxillary tuberosities. And where's the vibrating line? The vibrating line is the indication of the posterior extension for your denture. And the denture for sure should go through the hamular notches. So this is the responsibility of the dentist to make sure the laboratory knows where the hamular notches are so that the denture can go back to those notches. And if you just send a cast, well, it's hard to tell sometimes, if somebody has maybe small tuberosities, well, how far back does the tuberosity go? So we're going to show in just a minute. I always mark that, and so that so I know, and then the laboratory would know. On the mandible, on our retromolar pad, we need to have the impression include the retromolar pads. So the retromolar pads and the buccal shelves are the real important support areas for our lower denture. And of course, the lower impression should include the ridges and not be overextended, because if the impression kind of pushes the muscles, then as those muscles move upper or lower, then it makes the denture flop around. And so so if we know the basics, and I'm just going to show you an impression system. It's called the AccuDent system by Ivoclar Vivadent, and this is what I've been using for 40 years. But I'm not saying this is a recommendation, but I would say it might be a good idea to try it if the dentist is having problems with his impressions. It's an alginate, and you'll see it's really, really neat how it works, and it has trays and tray adhesive. So what's nice about this, the system here, we have an injection alginate, and then we have a tray alginate. The injection alginate it flows a lot better, so you can get it in areas that the buccal vestibule, so it doesn't push the muscles, and also it's non-slumping. So when you inject it somewhere, it stays where you inject it, but it doesn't run down the patient's throats like so many alginate impressions do. The pre-packaged is really nice. You have the same amount of alginate, and it's all sealed, and then you have the little vial for an exact amount of water, and so you get a consistency of your with the impression material for your impression. And I also will add too that just down here at the bottom, tray adhesive. Always the dentist should use tray adhesive with anything, any impressions that they're taking, any alginate impressions. Just the little retention, the little grooves, if the alginate kind of pulls out of one of those little grooves, then it doesn't go all the way back in. You've got a warped impression. So there's so many little things, and that's one of the things about the fundamentals are be careful with the little things and with the basics. And so this just shows a final impression at the upper, and you can see the pink around the border, that's the injectable part, and this is marking the vibrating line with indelible marker and marking the hamular notches. And so anyway, that's it. Excuse me. Okay. So here's Jim on the left, and just so I mark, he goes makes his, and in my courses I'll go over how you find and mark your vibrating line. But so if the dentist will mark exactly where the hard and soft palates come together, and this is where we want the denture to extend to, the laboratory knows, and it's not just a guessing game. And marking the hamular notches, it's so important. And so then on the injection, so the injectable alginate, there we have the tray. We mix up this runnier alginate and put it in the syringe, and so the tip of this syringe goes right back in your hamular notch, back there as far back as you want to get your impression. And then you come up in the vestibule on that one side, go to the other side, squirt some in the very back and come forward, and then put some up in the palate so you don't get a void, and then you put your tray in with the tray colloid, tray alginate, which is a lot firmer and it supports that injectable part, and let it set. And voila, you've got yourself a nice impression. It doesn't push the muscles way out, so we get a nice vestibular roll. And this, if you mark your vibrating line with indelible ink, that's transferred over to the cast when you pour it. So important for the dentist to communicate guidelines, what the dentist wants to the laboratory technician, and just some of the communication aids are, this is for the aesthetic wax rim contours, is an Papilla Meter or Papilla Meter, and the Alma gauge. We talked about the Alma gauge a moment ago. So let's just go on here. Here's the Papilla Meter, and so this is something that if you measure the width of the nose, and usually the width of the nose is correlated to the width of the canines, so the width of the anterior sextant of the maxillary arch, and then also this, here you can see at the bottom, it tells you the mold size of the tooth to use. So, so somebody that has a narrower nose, usually then the canines would not be as wide as somebody like Jim, and so, but this just shows that in her denture, the width of the canines correlates with the width of her nose. So that's just something quick. They say the width of the nose is 44 millimeters from the Papilla Meter, and you can use that to contour your wax rim. So these are things just to make things work quicker and easier. The Papilla Meter, this measures how far the lip extends down beyond the incisive papilla. So the Papilla Meter, this is the gauge down here in the middle. It has this little ledge on the inside which goes against the incisive papilla, and then the lip goes down over that gauge, like here on the left, and you can see that his lip is about 10 millimeters below the incisive papilla. And so if the dentist wants the laboratory to make the wax rim this length, you can say, using the Papilla Meter, you might say, I want it to be 11 millimeters. I want the teeth to show a little bit when the lip is relaxed. And then the laboratory can use this Papilla Meter to make the wax rim the length that the dentist needs it. So we know the width of the anterior from the Papilla Meter and the Papilla Meter here, and the Alma gauge also can let you know how far forward or how far down to set the maxillary anterior teeth in relation to the incisive papilla. So we want the wax rim, this about the base plate and the wax rim. So the laboratory is creating an arch in wax where they think the maxillary teeth will be. So you kind of look at that when you're making a wax rim. This is where you think the teeth should be. This is where I think the occlusal plane should be. This is where the anterior teeth should be. So then when it dimension mark, and it's going to be very close to being parallel to the horizon, and also anteriorly it's parallel to the aortragus line, Camper's plane. So this is this Swiss neck Western form of just a wonderful tooth. That's the way I just talked about that. And then just here, down here, as the wax is melting, as you're rotating it down, it just flows out. That there's a little channel in the back, so it doesn't just flow all over and make a mess. You can just have a little napkin down there to pick up the wax and stay clean. Now, this is a great one, I think. This is recording our vertical dimension of occlusion. That's how much space we have between our ridges, so we know how long to make our teeth and the denture base, and how to record vertical dimension of occlusion, and how to record our centric relation. And I call this verticentric. Vertical dimension of occlusion, centric relation. So it's very important to have an accurate verticentric record. You take a record and it's bites off. If your record is off, the denture is going to be off. So you've got to get a record that is centric relation and that has our vertical dimension. So look how easy, how much easier this is than using wax lens. Just relax their mouth and how the things feel. Put your mouth in a way that feels comfortable, and we're going to have them speak. And then we're just going to kind of work on these things to say, and maybe if they have an old denture, we're going to see what the vertical dimension of the old denture is and see how that looks. And so we come up with our 69 millimeters. So now in recording our vertical dimension at 69 millimeters, we want to put that on the articulator so that the vertical dimension is ready to make our denture, so that the teeth are at the right length in comparison to the ridges. So on the lower, we have a bar that has a little screw on it, and the upper has a tracing plate. And this is called a Gothic arch tracer, and this is what I'm. And what we have here is, here on the left, we have the tracing plate on the top, the bar on the lower, and this is a pin. And so we can screw it out or screw it down. So let's say we put it in the patient's mouth and we go and measure the distance between their nose and chin, and let's say it's 74 millimeters. We say, it's too far open. We want to have it 69 millimeters so that we have the correct amount of space between the ridges. So this little screw, you just screw it down some and then have the patient close, and then you measure it again. Let's say you're at 70 millimeters. Oh, we got to screw it down a little bit more, screw it a little bit more, and then 69. So with this then, when they close down, they have, this is a recording of the vertical dimension of occlusion, how much space we need to put, it goes between the ridges, and then we're going to put teeth and denture base in that area. So let's see the next here. This is how it is, and so this is the, let's say the correct vertical dimension the patient's at, and now we put ink on this tracing plate, and we have the patient slide around, and they can slide forward and to the side. Another nice thing about this is this puts perpendicular pressure on the upper denture base and the lower denture base. When you have wax rims, you know, the wax rims are moving around and the upper is falling down, so you're trying to hold it in, and you're telling, so this way the patient is closing down, they're putting there's pressure on this upper, pressure on the lower, the base plates don't move around, we have the correct vertical dimension, they slide around. When they slide back, they're sliding back into centric relation. So we can get a recording, and I'll show you how we do that on this tracing plate, and we say, here's centric relation, and that's the point where the mandible is in centric relation, the joints are in centric relation position when it records the relationship of the arches in centric relation. And you can buy a little kit, the Swiss Dent verticentric recorder, vertical and centric recorder. I think that Ivoclar Vivadent sells this. You can get it online. There are lots of places that do. But this is just, it has, you know, so either the laboratory can have it or the dentist can have it, but you have a couple of tracing plates. This is the bar that you put your screw on. This is marks a lot to mark your tracing plate. And there, this shows the marks a lot on the tracing plate. And the patient then is going to slide forward and back, forward and back. They can slide all around, but you'll see how far back they go because it makes it mark. So we get a little recording like this where they're going forward and back, and this is how far back they go, and they go off to the side, and sometimes they slide all over the place. And any movement that they do, like, great, you're doing great, yeah, I'm getting a recording of your bite, and they think, oh, this is really top notch. Nobody's ever done this before. Okay. So now, let's say we've got our recording here on the left, and now to record this, what we're going to do is we have a little disc, a little clear disc with a hole in it, and we're going to put that hole right over that centric relation. And then we're going to sticky wax it in position. So then when we put it back in the patient's mouth and the patient closes and that pin is in that little hole there, we have the correct vertical dimension, and the patient's arches are in centric relation. And we know, they're not forward, they're not off to the side, they're in centric relation. So this here on the left shows there's the arrow, and there's a little hole right over that, the point of the arrow. We're going to sticky wax it in place, and what I do, I just put a lot of sticky wax around the sides, and so nothing's going to move. And then we have the patient close down and have them slide until that pin goes right in that hole, and say, don't move. We've got the correct vertical dimension, the correct centric relation, and we're just going to put our bite recording material in, and there's the little pin right up in the that little disc, and so just put a lot of the recording material in, and then when we take it out of their mouth, there we've got it. And This is our upper base plate, lower base plate. There's our record right there. So we can put our casts in this. And it's so important to, I always, when I take it out of the mouth and I take my casts, make sure the casts fit in, make sure they're not hitting on the heels. Make sure also that the denture bases are not hitting in the back. But if everything's clear, then we're going to be sending it to the lab. And so if you're making dentures or probably laboratory techniques, you see this, and so you have the patient close into the wax, and it's at 74 millimeters. You need 69. Well, you've got to go back and heat this wax, and it has to be heated consistent, evenly. So, because if one place is more firm than another, when they're biting down, things shift, and then it's down to 70 millimeters. Oh, I got to get another millimeter down. You got to heat it again and go back. And you say close-centric relation. With all that stuff in their mouth, you don't know where they're closing, really. So you're just kind of close down, and you're just hoping. And but look at how much easier something like this is here, and you just get your little tracing, and you've got your vertical dimension, and you know right where you are, and then you just put your bite relation material in, and it's just such a cleaner way of getting your record. Okay. And so I say it's so important that we get an accurate record to give to the laboratory, and it's so important that the laboratory is careful in making and doing their mounting. And just, if they're just not careful and something moves, and also I'm going to mention the laboratory should not ever open the vertical dimension without talking to the dentist. And sometimes I know the laboratories will say, if I had more room, I don't have to grind off as much tooth. They'll go in there, I can set things up quicker, and they'll just change the vertical dimension. Well, that can just screw up the whole case. And, so that sometimes you just don't know, why isn't this case working? I was so careful, but every little step needs to be done carefully, but that mounting needs to be done well too. So there's my little right here. The laboratory should not adjust the vertical dimension of occlusion without speaking with the dentist. And now we're going to talk just a little bit about posterior teeth. Where do they go? How far? Where do we put them? And talk about lingualized occlusion, and also fallacy of the ridges. We can't just when the bone absorbs, it doesn't just absorb straight down, and where you have a nice ridge where the other ridge is. It goes lingually or buccally, and so it's not good to use the ridges as a guide for where the teeth should go. So, and I also recommend, it's just a better situation if the denture can be mounted on a semi-adjustable articulator with an incisal pin. This is just a stable way, and if the case can be done on the same articulator also, where the dentist can see it on the articulator, the laboratory can work on it. It's just a better way. But if a hinge articulator is being used, and I know they are an awful lot, just be real careful with it and make sure that little screw doesn't get changed. Because if it gets changed, you kind of don't know where it was. Okay. So I'm going to introduce here, these are called the Pound lingual control lines from Earl Pound. But the lingual control lines, this just gives us an indication of where to place the mandibular teeth. When the mandibular posterior teeth are placed, the further lingual they are, the more stable the denture is. But if they go too far lingual, then they get in the way of the tongue, and the tongue's going to kick them around. If they go too far out to the buccal, then that causes tipping of the denture. So if the lingual surface is between these lingual control lines, then the denture will be, the teeth will be in ideal position to have a stable lower denture. So, the lingual control line, there are two lines, one from the lingual aspect of the retromolar pad to anteriorly to the anterior of the canine, and then from the anterior of the canine to the buccal aspect of the retromolar pad. So, of course, we should have our retromolar pads marked on our casts, and then, so should we put our teeth in or out? Well, we can decide how far we should go in or out according to the upper. If we have a large upper arch, then the upper teeth might want to be a little wider, and then we bring the lower teeth out, but we would never bring them further out than the lingual of this lower tooth being between those lingual control lines. So this is just something when the case comes back to me, I'm always just check right away to make sure that the teeth are, the posterior teeth are set appropriately. And another, it's getting a lot more recognition now, is our lingualized occlusion. Dr. Pound talked about this for years and years. And what lingualized occlusion is, it is the only contacts of the upper and lower posterior teeth is the lingual cusp of the upper tooth contacts the central groove of the lower tooth. And what that does is that puts vertical pressure on the upper tooth, on the upper denture and the lower. If we're doing something like this, where we have teeth hitting inclines, and that can cause lateral movement. Plus, it's so much harder to adjust, you know. So where is our interference? What should we be adjusting? This here, the only thing you're adjusting, so if this buccal cusp is touching that buccal cusp, you're going to either reduce the lower or reduce the upper, so they're not touching. And if we're hitting harder on one area than another, then the only thing we're going to do is we're going to adjust this lower and take this central groove down. We almost never grind on this upper lingual cusp, because if you do, then we like it to be sharper. And so you're grinding it down, it makes it a little duller. But some nice, so here is our, so if we use an anatomic upper tooth and a semi-anatomic lower tooth, we have a nice aesthetic setup. You know, these cusp teeth are beautiful teeth, and so they look nice, having nice cusps, and then we have our contact there in the central groove. Some people like to use a flat plane lower. It's not near as aesthetic, but it still has the same concept, that the only thing that it's touching is on that lingual cusp. And so as the patient slides back and forth, we can actually much easier to balance the occlusion on both sides if you want to go into that, doing that. So, but anyway, it's a beautiful setup, and a lot less lateral forces on the dentures. Freedom of movement. And this is just to show here on the right side what it would look like to have these lingual cusps touching right in the central groove of the lower. So you have something like that, and it's so much easier to adjust the occlusion. We're going to talk in a minute about my ideas on adjusting occlusion. Got some real exciting concepts there. Wax try-in appointment, I think, so important that we're going to look and make sure that the central, that the midline is on, and we got our occlusal plane parallel the horizon. And so if things are okay, then another thing, if we look and we see that there's a space between the teeth and the mouth, we have a mounting problem. We can't be delivering a denture that has something like this. So if it goes in the patient's, if we look at it on the articulator and all the teeth are touching, but we come to the mouth and it's different, we have a space, what we need to do is to get another bite relation record and remount and reset the teeth. So, and I definitely recommend on the wax try-in using I have a big wall mirror. It doesn't need to be that big, but if something at least a couple, maybe 2 feet wide and 3 feet high, so the patient, when they hold the mirror out in front of themselves, they can kind of see their face and neck and hair and kind of see what things look like. I know some dentists just give the patient a little hand mirror when they put the wax try-in and the patient's going to evaluate it, and all they're doing just is kind of looking at their teeth, and they're not seeing what they look like with the teeth. I recommend both. We first have the patient look in the mirror and say, how do you like it? And then say, then I want you to look up close to make sure you like things up close. So this is a part of the presentation of our product with the patient to do a nice wax try-in appointment. Okay, now let's say that the wax try-in has been approved, the mounting is approved, and we're ready to process. It's so important, I think, to have a way of processing our dentures that controls the shrinkage of the acrylic resin. This makes a real difference. And so I know that the Ivoclar Vivadent, this is what we're using now. The laboratory is using Ivobase injection system. It used to be called the Ivocap. That was the previous system that they had. But and I'll show you a couple slides that I think are just real important, that when this acrylic shrinks, it warps the denture base, and we go to all this trouble to get a real nice impression, and then when we process it, the acrylic is shrinking different ways, and then so it changes the fit of the denture. So we get it, if we're controlling this shrinkage, we get a better fit and better retention and better success of our dentures. So just real briefly, this is the injection. So when the dentures, the upper and lowers, have been invested in this with the injection technique, they have the wax base, then the wax is eliminated, and then the acrylic is being injected in where the wax had been melted out. But as the acrylic sets, it's shrinking, and so what this does is it keeps injecting and putting pressure on the acrylic to fill in the places where the acrylic had shrunk back. And so let's see why that's real important here. Just briefly here, when you mix your powder and liquid together, and then when it polymerizes, it shrinks. We have shrinkage, so the volume is just less. So here is a representation of conventional processing, the way they used to, and I know a lot of people still do conventional processing of dentures, and I stress, don't do that. Here is the denture with let's say that we had the wax and it was the wax denture base, and it was all invested, and then we eliminated the wax and we put the acrylic in, and then the acrylic, as it's setting, it shrinks. And so this is our master cast. That's a representation just exactly where the tissues are, and as this shrinks and pulls back, well, that's a different shape. So no wonder the denture is going to cause sore places, and it's not going to fit as well. And I used to process my dentures, and it was called the hydrocast processing, and it controlled the shrinkage of the acrylic by, so this is when I'm breaking a case out, this is the set acrylic, and this is the matrix, the way this is where the wax was, and you see when it shrunk, look how far back it pulled from the stone. So if this were being done with the conventional processing, and let's say that this stone was your master cast, well, you can see that, I mean, it's just a different shape. And actually, just in a nutshell, we don't use this anymore, but it had a water pressure that put pressure down on the acrylic while it was shrinking and just plastered the acrylic to the cast, which was underneath. And that water pressure just holding the acrylic down, so all the shrinkage took place out on the outside, not on the tissue side. So I got really, really good results with that, just like with the IvaCap. So anyway, but just that, hopefully that'll remind you for laboratories to recommend to dentists, don't use conventional processing, use injection, or that's, one of the things about digital dentures now, that it controls the shrinkage. So, okay. And I recommend that the laboratory do a remount of the denture after processing, just to make sure that all we have occlusal contact of all the posterior teeth. And now we're going to deliver the denture to the patient and then say, hey, do you have any sore places? And he says, yep, I got one right here. And you're going to use our pressure indicator paste. And so you put that in the denture. And so this is a case that it's important. I wanted to just stress the tissue on the ridges has a little bit of give to it. It's thicker. The tissue at on the palate where the torus is very thin. And so when the denture goes in and it kind of sinks down a little bit on the ridges, and whammy, it hits this torus. And so if you deliver a denture and you have the interference on the torus, it's going to cause a big ulcer on that, and that's such a hard place. The tissue's so thin, so hard for that ulcer to heal. So we want to make sure that hopefully the laboratory always is going to put a little relief over a torus, and the dentist will be very careful and say, here are the places that it's hitting. We can see that with our pressure indicator paste, and then we're going to grind that out. And so that's why we want to make sure that we have enough thickness over the torus of the denture base so that we don't grind through the denture base. Sometimes I know laboratories will say, let's make it real thin here so it'll be more comfortable to the patient. Well, it might be more comfortable, but you might get a hole. So that's not good. 5 minutes? Great. And then, so the last thing I want here is adjusting the occlusion of the denture. And I recommend using Kerr occlusal indicator wax in the mouth for adjusting the denture occlusion. So if you have your dentures in the mouth, you've just delivered them, and you put articulating paper in, that's what Everybody does. And that patient goes tap, tap, tap. You got marks all over the place. The dentures are moving because they're on soft tissue. So it marks on the left, it marks on the right because the dentures kind of adjust so that everything's touching. And then so dentists kind of start grinding. This cur-occlusal indicator wax that comes in these little strips. And if you put it on the lower posterior teeth and put it over the teeth, and then you take it and put it in, just dip it in hot water, about 140 degrees, and just goes in and out. That makes the wax soft. It adds a little softness to it. Put it in the mouth and tell the patient to close. And so they're closing into equal pressure because they're closing into wax. They're not hitting the denture. They're just closing into wax. And when we see that, we penetrate through, like in this point here, actually this move, so we have occlusal contacts. We can just look at the wax and say, we've penetrated all the way through back here. We've penetrated all the way through here. We've penetrated all the way through here. But the other places, you can see there's no contact back here at all. So we want to grind these places down. So if we take this little, it's a little wax pencil that comes in the kit. And if we just mark those little places where they penetrated through or very close to penetrated through, we say those places, those are where our first contacts are. And then we've marked those places, and then we take our burr and just adjust those areas, and then we put some more wax on and do it again. Then we just keep adjusting it until we have contacts of each of the teeth. And the denture is not wobbling around. And so often our problems with soreness after we deliver dentures is it might be that the contact is hitting first back here, and the patient, if the occlusion wasn't adjusted adequately, they're hitting here, well, that can cause the whole denture to scoot forward, and the patient has a sore up over here because it kind of pushes the denture into the gum on the other side. And so then what the laboratory, what the dentist does is they start grinding over here when back here is where their problem is. So this way with cur-occlusal indicator wax, it's just a way to get the occlusion, and it just helps so much have a nice stable occlusion and centric relation. So those are things we talked about, and I thank you. And so I have a little handout for you. It has my contact information if anybody has any questions after this or right now. So Ellie, I'm done. Thank you so much.
Perfect.
They were great.
Thank you. Really appreciate it, Dr. Stromer.
Pleasure.
I'm honored having you. Just a little reminder for the attendees that were not here for the lecture that Ivoclar is doing the innovation tour. It's going to be stopping in Dallas on April 19th and 20th. Please stop by our booth and pick up some flyers and register. You'll get to see all the new equipment and material that we bring to you. Also, it's going to be, the next stop will be in San Antonio and Houston. And Trish will have